Today, we are covering inflammatory bowel disease, focusing on how the NCLEX will test your ability to differentiate between Crohn's disease and ulcerative colitis. The exam will not ask for a simple definition. It will present a clinical scenario and expect you to identify the correct disease based on specific findings. The most significant difference lies in the location and depth of inflammation. Ulcerative colitis is confined to the large intestine, starting in the rectum and progressing upward in a continuous, uninterrupted pattern. It only affects the innermost lining, the mucosal layer. In contrast, Crohn's disease can occur anywhere in the GI tract, from the mouth to the anus, and it presents in patches with healthy tissue interspersed between diseased areas. These are called skip lesions. Crucially, Crohn's affects all layers of the bowel wall, which is known as transmural inflammation. This single fact explains its most tested complications. Because it goes through the entire wall, Crohn's can form fistulas, which are abnormal connections between the bowel and other organs or the skin. An exam question describing a patient with a perianal fistula should immediately make you think of Crohn's disease. Ulcerative colitis, being superficial, does not cause fistulas. Instead, its hallmark manifestation is frequent, severe, bloody diarrhea, often containing pus and mucus. The NCLEX loves to test this distinction. If a question emphasizes bloody stools and anemia, it's pointing you toward ulcerative colitis. A helpful mnemonic is to think of Crohn's as a crooked cobblestone road that skips all over from gum to bum. For ulcerative colitis, remember UC for ulcers in the colon that are continuous. Exam traps often involve select all that apply questions. For a Crohn's patient, the correct answers would include options like fistula formation, steatorrhea or fatty stools due to malabsorption in the small intestine, and a cobblestone appearance on colonoscopy. For ulcerative colitis, expect options like tenesmus, which is a painful urge to defecate, severe bloody diarrhea, and the potential for toxic megacolon. Pharmacological management is another key area. Corticosteroids like prednisone are used for acute flare-ups in both conditions to reduce inflammation, but they are not for long-term use. For maintenance, especially in ulcerative colitis, aminosalicylates like sulfasalazine are common. For severe disease, immunomodulators and biologics are used, and the number one nursing priority is always monitoring for signs of infection due to immunosuppression. Nutrition is critical during an acute flare. The exam will test your knowledge of a diet designed to rest the bowel. For both conditions, this means a low-residue, low-fiber diet that is high in calories and high in protein to promote healing and prevent malnutrition. Finally, surgery provides a definitive cure for ulcerative colitis. A total colectomy removes the diseased organ, resolving the issue. However, surgery is not a cure for Crohn's disease. While diseased segments can be removed, the disease can recur in any other part of the GI tract. This is a fundamental difference and a very common topic for NCLEX questions.